With great pleasure, I would like to introduce our speaker, Dr. Wani. He has significant teaching experience. He acquired the degree of Bachelor's of Physiotherapy from VSPM College of Physiotherapy, Nagpur, and completed his Master's in Physiotherapy from Ravi Nair Physiotherapy College, Wardha, under MUHS Nasik. He acquired his PhD degree from MGM Institute of Health Sciences, Navi Mumbai, under the able guidance from Dr. Rajni in 2018. He is postgraduate teacher since 9 years under MUHS and is also PhD guide in physiotherapy at MUHS Nasik, having 3 PhD scholars under his guidance. To put light on his work experience of 15 years as an academician, he is presently working as professor, head of musculoskeletal physiotherapy department, and a PG and PhD coordinator at MGM Institute of Physiotherapy, Aurangabad. It's a pleasure to have you with us, sir. Handing over the session to you.
Thank you for the wonderful introduction. Now I'll start with the lecture. Fine. Yeah. Good afternoon, everyone, and welcome to the today's lecture on relationship between adhesive capsulitis and metabolic disorder. As we explore this topic, let's start by setting a stage with some background information about it. Adhesive capsulitis, as we all know, is also commonly called as frozen shoulder. It is a common condition which is characterized by stiffness, pain, limited range of motion at the shoulder joint. It affects approximately 2 to 5% of people amongst the general population, with higher prevalence rate of for the women. On the other hand, the metabolic disorders are also common in the general population, such as diabetes, obesity, dyslipidemia. Then have these are also common. These conditions affects the body by inflammation, oxidative stress, which can cause adverse effects on the health and musculoskeletal system. Recent studies have suggested a potential link between the adhesive capsulitis and some metabolic disorders. For example, the research has shown that the individuals with diabetes may have um, adhesive capsulitis, and that those with frozen shoulder or adhesive capsulitis are at more risk to have metabolic disorders. But what's it's there behind this connection? Is it simply a matter of coincidence, or is there any underlying mechanism to play? Throughout this lecture, we will go through the current evidence and try to explore the possible relationship between the adhesive capsulitis and metabolic disorders. So let's get started with the lecture by having just a background information about the adhesive capsulitis and its pathophysiology. The learning objectives for this lecture to revise the basic background information about the adhesive capsulitis, to understand the various risk factors for the development of adhesive capsulitis along with its pathophysiology, to understand the relationship between the adhesive capsulitis with the various metabolic diseases. So the true frozen shoulder is happens because of adhesive capsulitis. The term adhesive capsulitis, frozen shoulder, periarthritis shoulders, these are all the terminologies we use for shoulder pain and mobility deficits. But it is universally accepted that the adhesive capsulitis is a more appropriate term to uh, comment or to diagnose for shoulder pain and mobility deficits. Having international classification of diseases 10 version also having giving a coding that F75, sorry, M75, and ICD-9 have, which is commonly used in US, they have rated as 7 to 6. Based upon the epidemiological data, the prevalence rate of adhesive capsulitis is found between 2 to 5% among the general population. Coming to the structural impairments related to frozen shoulder, it's usually involve the capsuloligamentous complex and the musculotendinous structures around the shoulder complex. Pathoanatomically, we can divide it, the involvement of those structural impairments into non-contractile structures and the contractile structures. Many studies have already proven that the non-contractile structures around the shoulder joints are commonly involved, such as synovium, joint capsule, rotator cuff interval, then coracohumeral ligament, and these studies have confirmed this non-contractile changes in patients with adhesive capsulitis with proper ultrasonography studies or radiographically or MRI studies also. They have confirmed that these non-contractile structures are involved in adhesive capsulitis. However, very limited studies are found to confirm the contractile structures are involved into adhesive capsulitis. During my PhD course, I worked upon this, that to explore the relationship of the contractile structures, are they involved into adhesive capsulitis and not. So the major findings of the studies were we found out that the cross-sectional area of rotator cuff was found to be reduced, that is muscle atrophy, along with the EMG analysis we have done for the shoulder muscles, which shows that reduced recruitment was observed in the patients with adhesive capsulitis. Reduced recruitment in some shoulder muscles, the muscle activity was found to be reduced. Now the clinical course or the symptoms. The adhesive capsulitis is having a gradual or a progressive onset, which leads to shoulder pain and mobility deficits. And it may range from 3 months to 6 to 24 months. Total course duration is this. As we all know, the adhesive capsulitis may be divided into three different stages: painful stage, frozen stage, and the thawing stage. Painful stage is the freezing stage in which the shoulder pain is more prominent. And as the patient goes into the frozen stage, the patient may have reduction in the pain and increased shoulder stiffness. In the third phase, the range of motion of the shoulder joint gradually increase, and it will respond properly to the stretching exercises and the treatment. If you see in this graph also, the immobility of the shoulder joint is more in the second stage, and gradually it is increasing from painful stage to frozen stage, and then it is again reducing in the thawing stage. Total course duration may last from 6 to 24 months. The types of adhesive capsulitis can be subclassified as a primary adhesive capsulitis and a secondary adhesive capsulitis. The onset of the primary adhesive capsulitis is insidious, and usually it occurs between the age groups of 40 to 60 years, where there is no cause. This cause is unknown. In the secondary adhesive capsulitis, the uh, shoulder pain and shoulder mobility deficits are there, but secondary to some diseases like rheumatoid arthritis, osteoarthritis, some secondary to trauma to the shoulder joint, prolonged immobilization, or secondary to some systemic diseases. This can be nicely explained with this diagram. Frozen shoulder can be divided into two: primary, that is called as idiopathic, having unknown cause, and secondary frozen shoulder or adhesive capsulitis secondary to some disorders, can be a systemic like diabetes, hypothyroidism, hyperthyroidism, and the extrinsic factors like cardiopulmonary diseases, cervical disc, CVA, humeral fractures, Parkinson's disease. Some intrinsic pathologies are also um, can cause frozen shoulder. That is, intrinsic means the shoulder around the shoulder disorders like rotator cuff tendinitis, rotator cuff tears, bicipital tendinitis, then calcific tendinitis, acromioclavicular arthritis also may lead to a frozen shoulder or adhesive capsulitis, that is secondary. Moving ahead with the risk factors for development of adhesive capsulitis. The main risk factor is age between the 40 to 65 years, in which the 70% chances are there to have this adhesive capsulitis to the females. This is the first risk factor. Second is patients with previous episode of adhesive capsulitis in the contralateral limb have chances more to have frozen shoulder in the other or the contralateral limb. Preceding trauma to the shoulder joint again can be one of the risk factors for the development of adhesive capsulitis. Some studies says that HLA-B27 positivity also might be one of the risk factors for development of adhesive capsulitis. As I told, prolonged immobilization of the shoulder joint also can develop the frozen shoulder in the later stages. Several risk factors like systemic diseases like diabetes, cerebrovascular accident, thyroid diseases, autoimmune disorders, coronary artery disease are also a major risk factors for development of adhesive capsulitis that we are going to discuss later in detail. Heart and the neck surgeries, Parkinson's disease, smoking, thyroid diseases, and chronic regional pain syndromes are also contributing factors for development of adhesive capsulitis. One of the study has already proven that pre-diabetic patients are also having a risk of having development of adhesive capsulitis. One of the another theory it is I came across like due to the modern trends of sedentary lifestyle, we don't use our upper limb or more specifically shoulder joint for some overhead activities. So because of that disuse or we don't use this shoulder for activities which are done overhead, underutilization of the shoulder may also lead to the frozen shoulder or adhesive capsulitis. Age is also age-related oxidative stress or the pro-inflammatory cytokines also can cause the adhesions and connective tissue changes in the joint capsule of the shoulder joint may cause the frozen shoulder. One of the theory is explained by some author recently to explain the pathophysiology of adhesive capsulitis is inflammation fibrotic cascade theory. So the pathophysiology of this frozen shoulder can be explained by having the chronic inflammation um, may lead to proliferative tissue fibrosis. And because of that, the fibroblast will get activated and along with the neoangiogenesis and neo innervations also happens. These changes are happens into the tissues around the shoulder joint like capsule, tendons, ligaments may lead to shoulder pain and loss of range of motion or reduced shoulder mobility of the patient. So this is one theory. Another theory again it is put forward nowadays is continuous low grade inflammation and along with the stress. So low grade inflammation is commonly present in the aged population or elderly people, and stress is there because of the modern lifestyle factors. So this chronic stress along with the low grade inflammation due to aging may activates the stress systems, and because of that the excessive production of ROS, that is reactive oxygen species, and the advanced glycation in products will be there in the tissues will lead to increased chances of capsular fibrosis around the shoulder and may lead to frozen shoulder. So this theory also explains the pathophysiology for development of adhesive capsulitis. Now coming to the main topic for the today. Uh, is the relationship of adhesive capsulitis with various metabolic diseases. So we are going to correlate the adhesive capsulitis with some diseases, specific diseases like diabetes, then thyroid diseases, and age-related metabolic diseases. So we'll start with first correlating it with the diabetes. So these are the some studies which are already available in the literature proving that the adhesive capsulitis is more prevalent in patients with type 2 diabetes. In a study done by us in the central Maharashtra region, we have found out around 50% of people with diabetes may have adhesive capsulitis. Overall prevalence for frozen shoulder in patients with diabetes is uh, 1 to 3 times higher than the individuals without diabetes. That is, the frozen shoulder is more common in patients with diabetes again. In another study also, they have proven the incidence of the diabetic population is, that is, incidence of frozen shoulder in diabetic population is quite 10 to 36% higher than the general population. So all these epidemiological studies have confirmed that the frozen shoulder on adhesive capsulitis more appropriately is more prevalent in patients with diabetes. Now, why it is so? Uh, the prevalence of shoulder dysfunctions in diabetes globally it's around 10 to 40%. In India it's ranging from 20 to 50%, but the mechanism for the development of shoulder dysfunction in patients with diabetes, it remains unclear. We'll try to just find out what may be the reason of development of this adhesive capsulitis in patients with diabetes. So the main impairment in patients with diabetes is impaired glycemic control or prolonged hyperglycemia. It was already proven recently also that HbA1c, which is a marker of impaired glycemic control, having a strong relationship with the production of um, AGE products, that is advanced glycation end products, which may result in tissue fibrosis, capsular fibrosis, and may be one of the cause for frozen shoulder. So HbA1c is considered to be as a significant marker for the development of musculoskeletal problems. So along with this, the main now pathophysiologically, in the patients with prolonged hyperglycemia, there will be the increased glycosylation process, glycosylation of collagen protein. Now the glycosylation means the attachment of your carbohydrate molecule with the collagen protein. More specifically, the attachment of the carbohydrate molecule with the amino acid which is present in the collagen protein, which leads to increased stiffness of the collagen fibers. Due to hyperglycemia, alterations in the collagen synthesis and repair happens. Because of that, there will be the excess depositions of collagen fibers in the tissues like capsule, cartilage, or the tendon around the shoulder joint. The, um, because of hyperglycemia, there will be the increased accumulation of the advanced glycation end products, increases the cross-linkings in between the collagen fibers, muscles, tendon, ligaments, which facilitates the formation of adhesions and fibrosis in the joint capsule of the shoulder joint, may lead to frozen shoulder or adhesive capsulitis. Increased collection of, this is also one of the main reason, because of the prolonged hyperglycemia, there may be a increased collection of systemic inflammatory cytokines leading to capsular hyperplasia, and the contractures may lead to adhesive capsulitis also. Now, the increased stiffness at the shoulder joint was found by some authors in patients with shoulder dysfunction due to the microstructural reorganization of the collagen fibers lead to increased stiffness and increased your reduced mobility also. Now, in a histological study recently, I have gone through this article. The histopathological analysis also done in patients with adhesive capsulitis and diabetes patients. They have found out that they found out that the increased immune cells, cytokinins, then the vascular endothelial growth factors, and the advanced glycation end products are present in the tissues of non-contracted tissues of these such kind of patients, and which are the primary factors which may cause synovial hyperplasia, vascularization, and the rotator cuff interval fibrosis, which is also one of the cause for development of adhesive capsulitis. In addition, they have also found out this nerve tissue biomarker S100 was also present in those tissues which may be linked to the severity of pain which is expressed in patients with adhesive capsulitis. So this histopathological studies also confirm that the diabetes is associated with the adhesive capsulitis. In a summary, we can just summarize the mechanisms for development of adhesive capsulitis due to the prolonged hyperglycemic environment in the patient's body. First is formation of collagen cross-linkings by the advanced glycation in products, which may lead to the fibroblast proliferations and cytokinins release. Second may be due to the chronic inflammatory mediators collection, the increased collection of chronic inflammatory mediators like cytokinins, TNF alpha, IL, interleukin 6, which your enhances the process of inflammation and may lead to the further that cascade that we have discussed earlier. Then another theory can be the adipose tissues collection in the body also promote the synovial fibrosis, can also linked with the capsular tightness in patients with adhesive capsulitis. So these are the three mechanisms. Now, second, disorder is the thyroid disorder. The prevalence of thyroid disorders in patients with frozen shoulder, it was found around 13.5%, and which is more common in females than males, ranging age having 40 to 65 years. Another study have confirmed the prevalence of adhesive capsulitis in patients with thyroid disorders. It was around 11%. 17.4% having subclinical thyrotoxicosis also have frozen shoulder. One of the study done, that is longitudinal based study done in the Taiwan also, they have confirmed that the hyperthyroid patients, the patients with hyperthyroidism also have 1.225% higher risk to develop adhesive capsulitis. Another study have also confirmed 13% with patients with hypothyroidism may also have the adhesive capsulitis. The proposed mechanism for the development of adhesive capsulitis in patients with hyperthyroidic patients with hyperthyroidism are due to the hyperthyroidism, the activation of the sympathetic nervous system is increased. Because of that, the fibroblastic proliferation happens. Because of this, the thickening of connective tissues like capsule, ligaments, tendons around the shoulder joints happens, which contributes for the development of adhesive capsulitis. So in a recent study, they have confirmed that both the thyroid conditions like hypothyroidism and the hyperthyroidism both are um, related to related to the development of adhesive capsulitis. So hypothyroidism, the link between the hypothyroidism and the frozen shoulder, they have discussed, like because of the elevated TSH level in hypothyroidic patients and the low thyroid hormone levels may lead to slowed um, metabolism and glycosamine buildups in the tissues, which contributes for the further inflammation and the fibrosis of the capsule, and the non-contractile structures around the shoulder joint may contribute for the development of adhesive capsulitis. Another condition related to thyroid is hyperthyroidism is also linked with frozen shoulder because of the hypermetabolic state and the lower TSH level in patients with hyperthyroidism. There will be the increased demands, metabolic demands, and oxidative stress which can cause continued inflammation and increased pain sensitivity may lead to the development of adhesive capsulitis later on. Another metabolic conditions that we are going to discuss is about the hyperlipidemia, um, more appropriately dyslipidemia, because both hyper and hypolipidemia also may cause the adhesive capsulitis. First, we'll see about the hyperlipidemia, which is the proposed cause, but not it is one of the risk factors for development of frozen shoulder. Hypercholesteremia and the inflammatory lipoproteinemias also have association with the primary frozen shoulder, which may be associated with diabetes. The altered lipid metabolisms in frozen shoulder is also studied previously for confirming is it related to the development of frozen shoulder or not. On metabolic profiling of such patients with frozen shoulder or shoulder stiffness, they have found out that the levels of lipid-related metabolites like sphingomyelin or the glycerophospholipids are present in the tissues surrounding the surrounding the shoulders. They are prominently present in the tissues of rotator cuff interval, and they were present in the anterior capsule, which was positively correlated with the serum level of cholesterol in patients who had rotator cuff tear or stiffness. So these lipid related metabolites were found out in the tissues of patients with frozen shoulder or stiffness. The proposed mechanism for the connection between the lipids, uh, hyperlipidemia with the frozen shoulder is the lipids may accumulated into the extracellular matrix of the tendons, may lead to the changes in the mechanical properties of the tendons and other non-contractile structures, may lead to the reduced mobility of those structures, can contribute for the development of adhesive capsulitis. Another the point of discussion or debate point for debate might be the statins. These are the uh, medications which are used for lowering the lipid levels in the patient's body. So some studies says that there is a relationship between the use of statins for the development of shoulder disorders. Some disagrees, and some study disagrees to this. So the studies for confirming the relationship between the use of statins with adhesive capsulitis is still under research, but I have quoted some studies here to discuss the relationship between the two. Some study says that the lipid lowering medications are not at all um, increase the risk for the development of frozen shoulder. On the contrary, reducing the serum lipids or the protective anti-inflammatory and the antifibrotic effects of statins may reduce the chances of development for the frozen shoulder. So that means if the patient is on statins, so the chances of frozen shoulder might be reduced because of the effects of anti-inflammatory and antifibrotic effects of statins. So this is another study. Recently, one study have proven that the statin use of statin medications for a longer duration may increase the risk of development of frozen shoulder compared to non-statin users. So these studies have confirmed that there is the some studies says that statin is responsible, maybe related to the development of frozen shoulder, or some says some there are some contradictive studies. So we have to just correlate all these things with the patient's clinical conditions and take the decisions. Now, next is the age-related metabolic syndrome and the low-grade inflammation. So, age-related metabolic syndrome consists of some findings or symptoms like excessive abdominal adipose tissues, elevated triglycerides, then higher blood pressure, fasting, blood sugar levels are increased, decreased HDL levels. So these are all the symptoms or metabolic syndrome in patients with higher age groups. So this can be one of the cause for the development of adhesive capsulitis. In a systematic review and a prospective cross-sectional study done by some authors have proven the association between this age-related metabolic syndrome with the rotator cuff related shoulder pain um, and confirm that there is a relation between the two. Another case control study has also confirmed the relationship between the metabolic syndrome and the development of adhesive capsulitis previously. Now, till now, we have discussed the associations. We tried to correlate the metabolic disorders for the development of adhesive capsulitis, how they are correlated with each other, what are the mechanisms which may cause uh, the adhesive capsulitis due to the presence of metabolic disorders. Now, at the end of this short lecture, what are the take-home messages we can take by this lecture are first, there is the definite association between the two, that is metabolic disorders, various metabolic disorders like diabetes, thyroid, age-related metabolic disorders, dyslipidemia with the development of adhesive capsulitis. The exact mechanisms underlying the association, which confirms that there is the association between the two, it's still under study, but the possible explanations are already discussed in the previous studies as prolonged hyperglycemia, chronic low-grade inflammation because of the oxidative stress and the hormonal imbalances like in the thyroid dysfunctions. Now, the clinical implications, the patients with adhesive capsulitis should be always screened for having underlying some metabolic disorders and vice versa also. It is very important to diagnose the patient having metabolic disorders on time and should be treated aggressively with the medical treatment along with the physiotherapy treatment also. Lastly, the research is also needed. More studies are required to fully understand this relationship between adhesive capsulitis with the metabolic disorders. to plan more appropriate therapeutic strategies for the adhesive capsulitis. So that's it. We have I tried to correlate all these common metabolic disorders with the adhesive capsulitis. Thank you so
Thank you so
much.
much, sir, for the insightful talk. A few queries, sir.
Yes.
The major one being, can metabolic disease control, like if I have diabetes and my sugar levels, if I'm controlling them, can improve the response to other treatments in adhesive capsulitis?
Yes, yes, rightly said. It is always advisable to control the hyperglycemia, prolonged hyperglycemia with the medications for getting good or better results with physiotherapy. Uncontrolled diabetes or uncontrolled hyperglycemia may not give you the good or appropriate results with our only physiotherapy. So the medications are should always be primary line of treatment, and along with that, proper appropriate physiotherapy should be advised to the patients with diabetes.
So, can you explain a little how do metabolic disorders or factors influence the prognosis or severity of the uh, disease or impairment and outcome in a prolonged, like long term?
Yes, the factors that it prolong, as I already told, the prolong like HbA1c. Suppose if the HbA1c shows that the uncontrolled diabetes is there or higher, like 8 or 9 or 10 HbA1c, if it is there, then it is already found out that the uh, disability associated with the adhesive capsulitis is found to be more in patients with uncontrolled diabetes. Like, but the studies on the your thyroid diseases, the controlling the thyroid diseases, if is it giving you the good outcome related to frozen shoulder or adhesive capsulitis, it's not there, I think. But definitely in diabetes patients, if it is controlled diabetes, then you can have or you can expect good uh, outcomes with the physiotherapy treatment.
Thank you so much, sir, for addressing our queries. Um, any parting comment that you would like to give to our viewers, sir?
Yes, important message that I want to tell you is, if the patient is coming to you with shoulder mobility deficits along with the shoulder pain due to some any of the disorders, it is written in the medical reports like um, rotator pathology, impingement syndrome, never overlooked or never or keep it in mind behind that patient may have developed the adhesive capsulitis later on, that is secondary adhesive capsulitis. And also check the medical reports to have some metabolic disorder associated with these shoulder problems. That means it is always better to uh, manage some associated metabolic disorder um, along with our physiotherapy treatment for better outcomes. So if sometime patient will come to us with shoulder mobility deficits with no history of diabetes, that patient may have the undiagnosed diabetes. So in such patients, you can advise the patient to go for the blood profile to confirm whether the patient is having diabetes or not, refer them to appropriate practitioner and start with the medications along with the physiotherapy treatment.
Thank you so much, sir, for
Yes,
addressing such a vital topic of daily routine, which we see but maybe completely never understand. I
yes.
would also like to take this opportunity to thank our management, Mrs. Manisha Sangvi and Dr. Parag Sancheti, also our principal, Dr. Apurva Shimpi, for providing us with such a beautiful platform. I would also like to thank our Physio TV team, who is tirelessly working towards the smooth running of the channel. And last but not the least, to our eminent speakers and viewers, without whom it would not have been possible. Thank you so much, sir.
Thank you so much for giving me the opportunity to talk on this great platform. Thank you so much.
The pleasure is all, sir. All ours, sir. Thank you so much.
Thank you.